It's time to get the story behind the story. Interviews with newsmakers, news breakers, and Vermonters making a difference. WCAX presents 802 News with Mark Johnson. Here's Mark.
For decades, Vermont public policymakers have decried the high cost of medical care and rapidly increasing health insurance premiums. Earlier this year, a new advocacy group formed to highlight and address the problem. Members of Vermont Healthcare 911 say the affordability crisis in Vermont healthcare is getting worse, affecting the care people receive, hampering businesses, and contributing to school budget defeats. Last week, VHC 911 members met with the chair of the Board of Trustees overseeing the UVM Health Network. Prior to that meeting, I met with VHC 911 members Lisa Ventris and Dr. Craig Jones, who are highly critical of the network's leadership and their attitude and approach toward controlling costs. The meeting with the board chair went well enough that they toned down the language in a letter that they were going to release to the public. In addition to public pressure from groups like VHC 911, the state's regulatory body, the Green Mountain Care Board, has also been sharply critical and has ordered the network to rein in the amount of revenue it takes in. We'll hear from VHC 911 members Ventris and Jones first. Later, I'll share with you the response from the network's Board of Trustees chair and outline the budget proposals for next year for the network's 3 Vermont hospitals. Those figures indicate the tide may be turning. Here's Ventris and Jones. Your group formed here back in January. Why this group? And I guess more importantly, why now?
So we officially launched in January as a new coalition, but Craig and others had been chewing on the question of why are Vermont's healthcare costs so high compared to the nation. They reached the point where they realized we need to take some action, we need to get organized, and one day Craig gave me a call, asked if I might come to a meeting to hear about what they've been up to, and in the course of that meeting they laid out the plan for this coalition to put some weight behind the inquiries that were happening informally. So we identified some leadership. So former Governor Jim Douglas and I agreed to serve as co-chairs. And then we went about building coalition members that would represent a diverse group of sectors of our economy, of our society. So business, educators, healthcare practitioners, labor union representatives, League of Cities and Towns, AARP, all kinds of diverse people who are being impacted by these out-of-control costs and this affordability crisis.
It's a really interesting story how it came together, because it was just a group of us, small group, meeting informally, talk about the question, why are our healthcare costs as high as they are? And in the course of the work I was doing at the time, I had run into some data comparing costs around the country at hospitals and health systems. It's a fairly robust data set. I began to look at it and give it to another one of our group, Tom Reese. He began to look at it. And we were pretty clear after not too long where the signals were all pointing, and that, in fact, our hospitals, in particular our largest hospital and health network, were very expensive, and very expensive compared to others around the country. And the timeline of that coincided with our health insurance costs going up and skyrocketing. So once we got kind of an objective look, I guess, at where we were sitting relative to the rest of the country, that caused us to kind of come together and say, we're going to do something about this. And I would say the real driver was that there was no public narrative, there was no public discourse around what the causes were. There was a public discourse around the problem. Everybody was upset about the costs. But the hospital association and the hospital leadership, particularly at University of Vermont Health Network, would point at the demographics of the state and say, that's our problem. They would say, we have people using a lot of health care. That's our problem. We're a rural state. That's our problem. And we were listening to this, and in work around the country, we're really not that different than most other places in those factors, and it didn't match with the data. And last November, I believe it was, when there was this tension between the Green Mountain Care Board and the University of Vermont over the settlement, if you will, because they had taken in too much revenue. And the University of Vermont Health Network came out and said they were going to cut services. And that really, that was it, because we could see in the data that wasn't the need. There was other places that they could save costs. And we decided to put a public voice to this. And the goal of the coalition, Vermont Healthcare 911 coming together, was to put public information out there and support leadership in this state to do the right thing and get after the real drivers of the costs in the state.
You led the effort with the Vermont Blueprint for Health. What did that achieve?
So that was, in my mind, reading the legislation back in 2007, was visionary, and Vermont was really headed in an incredible direction. The rest of the country was talking about these things, and here was legislation that was pushing in a new direction. And the direction was that they were going to finally invest in what I call the ground game, advanced primary care, teams of people in communities to support services, not just medical, but the social and demographic contributors to poor health. So they were going to really make an investment in a better base of health care for the whole population. And that's what the blueprint was intended to do. And when Governor Douglas launched that, in his mind, and rightfully so, he said, we got to get control of chronic conditions, get upstream, do better preventive care, and that's going to help us control costs and improve affordability. And he was right. And so the accomplishments, I guess the purpose, was to work statewide and try and get all of primary care to elevate to a new level and do better preventive care, more complete care, pay them differently so they had the capacity to do that.
And not wait for people to go to the hospital.
Yeah, and put teams of people, social workers, nurses, dietitians, to support those populations. That was a major accomplishment at that time for a state to lead that kind of effort statewide. And those teams still go today.
Go back here, you talked about how it isn't demographics. It's not because we're all getting old. It's not because we're a rural state or we're small. So what's the problem?
So the problem, is that we have a very expensive health network that is overloaded on administrative and management costs, which is a conscious choice by the leadership of that network. And we have also learned that combine that with exorbitant pricing of pharmaceuticals, combined with the fact that there are trends indicating reduction in the amount of patient-facing labor within the network, all of these issues are pointing to a lack of access, decline in quality, an increase in costs that have to be faced and addressed by the administration. What we're pointing to is we know that we can find savings within this healthcare system. We don't think we need an increase in insurance premiums this year. We've started to point to areas where we can find savings if the leadership, meaning the network CEO and the Health Network Board of Trustees, can actually make those difficult decisions.
The real fundamental problem is cost at the hospitals and the health network. The management and administration we're top heavy, is the bottom line in the University of Vermont Health Network. We have a lot of layers of management. And I'm not talking just about executive leadership. What I'm talking about are the layers of management below that. When you talk to physicians, when you talk to nurses, the people that deliver care, I mean, these are incredible people. They're dedicated, they work hard, but they will, to a person almost, describe how there are layers after layers after layers of management. So if they want to get something done or improve something, whether it's in the surgical suite or whether it's in the medical care delivery, going through the varied layers of management to do something is complex. They'll describe when they go to management meetings how many people are filling a room in these management meetings. They're top heavy. And it's a natural growth over the last, most of the ones I talk to describe about 10 years. Physicians come in, nurses come in, and after a couple of years, being fully devoted to care delivery, they'll get moved into some portion of their time dedicated to management. And over time, they've accumulated many, many people, clinicians included, who are doing a lot of management time, less clinical time than they used to. And so we become a top-heavy organization. It's a natural course that happens often in healthcare systems and hospitals. The next thing is the network had some financial challenges back in 2020 in COVID period, and they've been on a course to rebuild their assets, their their financial assets, and they've done that very well. In conjunction with being expensive, having high operating costs, they've accumulated a lot of liquid assets, and you can see that growth over the last 4 to 5 years, and most of that has been fueled by revenue from commercial insurance. So basically, insurance has they have a monopoly. Insurance has had to pay them. Blue Cross Blue Shield of Vermont has to pay them. Blue Cross's premiums go up. People pay high premiums. That money is going into high operating costs at the University of Vermont Health Network and the accumulation of liquid assets. That's the trajectory that we've been on. Our other hospitals, there's so much attention paid to sometimes smaller hospitals around the state, and that do we need all these hospitals? Do they all need to deliver all the services that they do? And so there's questions around what the profile of services should be in each of the 13 or 14 hospitals around the state. And that's one thing. That's an issue that's being dealt with at the state and Agency of Human Services.
Right, well, and Tom Reese, who you mentioned, he and others have come up with reports showing that they're really on the financial ropes.
Right. Some of them are. That's correct. And some of them have high administrative costs. Others don't. Those are transformation needs for the other smaller and mid-sized hospitals. The cost driver in the state has really been the University of Vermont Health Network, and the University of Vermont Medical Center is the revenue generator. They charge, they bring in commercial profits. They can't force Medicare and Medicaid to pay differently, but they can force Blue Cross to pay differently. So they're the revenue generator for the network. Their commercial profit per discharge is one of the highest in the country, and that has grown over the last 4 to 5 years. That's what's fueling what is a top-heavy network and an expensive network, is that operating profit per discharge.
I talked to Dr. Steve Leffler probably 6-8 months ago at this point, and he says executive salaries, administrative costs are not that large a portion of the revenue. And he also talked about just this enormous cost of traveling nurses. Is that really the problem, or is that the one that you can get the public's attention on and get their dander up?
That's a great question. On the traveling nurse problem, that was a problem. But that was a problem for virtually every hospital and health system across the country during COVID. So that was a contributor to cost, no question, but it wasn't unique to Vermont. The issue around the costs, it comes out of data from national data sets, the Centers of Medicare and Medicaid data that has to be reported every year by hospitals and health systems. The RAND Corporation's use of that data to do a price transparency evaluation for every hospital across the country. It comes out of the National Association of State Health Plans using that Centers of Medicare and Medicaid data. All of these organizations using national data to compare hospital cost prices and bring some transparency. That's where the information comes from. Executive salaries are high, but we're really not focused in on the executive salaries. I think that's really important for the public to understand here. The executive salaries, Dr. Leffler is correct. That's a relatively small portion of the $3 to $3.5 billion a year operating cost that the University of Vermont Health Network has. We're talking about management layers. Many, many people, layers, chairs of divisions, sub-chairs to chairs, sub-chairs to sub-chairs. It's not the executive salaries here. Those are high. They get a lot of attention. But you're right. Executive salaries are high in other health systems and hospitals. We're talking about being top-heavy across the board in management layers.
Let me just make clear. So the University of Vermont Health Network are the 6 hospitals within the group, and the University of Vermont is one of those. And
correct.
3 of them are over in New York.
Correct.
Right.
Yes.
Okay, so Lisa, you ran the Vermont Business Roundtable. Help me understand why would it be in the best interest of the network to be top heavy with these layers of management? I mean, these are presumably pretty smart business people. Why would they construct something like that?
I think it's a governance framework that has evolved over time. In our conversations with leaders from the health network, they have shared with us that they have a model that has 9 layers of management within their superstructure, and they're working with a consultant to reduce that down to 7. So they are acknowledging themselves that they have overbuilt their structure. We have seen within the business community over time, given economic pressures and workforce challenges, that they have had to redesign and streamline the way in which they structure their businesses, their companies. But within this particular network, there has been an aggregation of that control and that oversight. So the question becomes, how do they planfully, systemically reduce the size of their administration without affecting patient services, but benefiting patients and reducing costs over time? That's the challenge that we want them to address, and that Green Mountain Care Board and the Agency of Human Services is also going to be pushing them to address.
So the growth has been, let me be blunt, sort of mission creep on steroids?
We would argue, yes.
Yeah.
Okay, but again, why would they, what's in their best interest, in the best interest of the network, to allow that to happen?
Good question.
Yeah, it is a good question. I don't think it's unique. I think it's a story you hear in other hospital health systems as well. And one of
probably other businesses too.
Yeah, most likely. I'm not a business person by nature. I'm a physician, and I work on healthcare delivery. But in my experience and my work around the country, and a great example would be Dr. Provenos, who testified to the Green Mountain Care Board not too long ago. He's told the story of reforming the University of Cleveland hospital system. Same story. Over time, they had accumulated so many layers of management and administration. They were inefficient, they were expensive, and quality was going down, similar to the pattern that we see here in University of Vermont Health Network. And he described what changes were needed, and it kind of tells a story. It's just that over time, clinicians, others, they want to be moved into roles, especially at an academic medical center. It's natural. They want to deliver care, but they also want to be viewed in a leadership role, in a management role, in a teaching role. And so there's this natural tendency to shift them into part of their time dedicated to that, part of their time dedicated to clinical work. Same thing, was at an academic medical center for over 15 years in USC in Los Angeles. Same tendencies.
Okay, why not leave this work to the Green Mountain Care Board? That's what the Green Mountain Care Board's for. They're the regulatory body. Why is your group needed? Why can't the Green Mountain Care Board just do this?
I think the greatest contribution we can make is to be the voice of the consumers. The parts of our economy, our schools, our municipalities, people who work within the health care system, people who are being impacted by the rising costs and reduced access, diminished quality. We need to be their voice. And so we're able to, we are not politically elected. We don't have a board that we report to. So we can be independent, curious people trying to just find the answers to these questions and sharing that information with Green Mountain Care Board, policymakers, the public. We've got this very robust communications platform through our newsletters in which we provide very sound, independent data and analysis that talks about the trends we're seeing and the drivers behind those trends. So I think we're providing a public service, And this is why I think Green Mountain Care Board, they have other fish to fry, and their mission is different. But ours is to really represent Vermonters.
Yeah.
Okay, but the Green Mountain Care Board has talked about many of the problems you've talked about. Do they not have enough power, enough enforcement power? Are they not strong enough? Why can't they? I mean, they're the people that have been designated to deal with keeping costs down.
Mm-hmm. Well, I think one of the benefits of this year's legislative session is that they have been authorized to have more oversight over the network, and that they did not have that before. And so this is, I think, part of where we started to turn our attention, because nobody really had that angle.
I would just to add to that, I think one of the things that actually got us together was, for about a decade or so, the Green Mountain Care Board has been overseeing hospital budgets and commercial insurance rates, and that clearly has not controlled the cost growth and the insurance costs.
And I think they'd even agree.
And they would agree.
Yeah.
But what we do see is they have a new leader now in Owen Foster, the chair of the Green Mountain Care Board, and he's taking a different look at this. So he changed the way the Green Mountain Care Board is looking at this problem fundamentally. And that's going to mean a different way of regulating of hospital budgets, and he did need the support of new legislation to allow them to do the work they need to do. But they also needed the leader who was willing to do it and take on the hospital system in a way that's constructive. He wants the best quality hospitals like we all do. We all want that. But he was willing to take on the issue of cost and quality, literally going at the heart of value. So with that change in leadership, what we saw was the public being told that the problem in the state was the Green Mountain Care Board. It's the state. They're over-regulating us. They're forcing us to cut services for you in Vermont because they won't approve our budgets that we ask them to approve. So we saw this narrative out there that in fact was undermining the credibility of the board. So part of the charge we took on was, let's go out, inform the public. What does the data say the problem is? And in doing that, effectively support, hopefully, the Green Mountain Care Board in doing the job they need to do to get our cost and affordability issues handled. So they are the ones to do it. You're absolutely right. But there does need to be public support for what is a very politically challenging process for the board. Taking on the hospitals in a robust way. But to do that, they had a big uphill fight. And the public needs to be aware of where the real problem is. It's not, if anything, it's maybe the regulators not having done a more complete job over the last 10 years.
You mentioned earlier how the Green Mountain Care Board ordered the network and UVM, the big kahuna within that network, to lower costs, and their reaction was to cut services. I think some people viewed that as arrogant, cynical. Did you?
Personally, I did, yes. And in fact, I know for myself and the others in our group that we're working with, we were actually stunned that an executive leader at the University of Vermont Health Network, the CEO, would come out and say the answer to us being asked to work on the affordability problem is to cut services for Vermonters, cut primary care, and cut dialysis and cut mental health beds. Stunned. That just was it was tone deaf, and it was the wrong reflex. And I think they're aware of that now.
Okay, you indicate that you think that they've heard that. Lisa, what indication is there that they've heard that and are going to change their way? You've written this letter that by the time this podcast come out will have been delivered to the Health Network trustees. I'm not getting any sense in this letter. It's pretty strongly worded that you're not hearing us.
In conversations that we've had with Steve Loeffler and others, they acknowledged that was not a good move on their part. They know that was not the message that should have gone out. What we understand just from living our lives is that culture is a really hard thing to change. And it is, to Craig's point, it has become so embedded in the structure that it will take time for people to recognize that they need to have a different profit motive, if you will. Their primary concern has to be the welfare of Vermonters, not the fiscal health of the institution, the health network. Now, do they need to make profits? Do they need to make sure that they have X number of days in the bank in case the wheels fall off and they need to, provide services? Absolutely. But at some point, you have to ask the question, why do you continue to grow in this manner when clearly you have a bloated administration, you have enough money in the bank, Vermonters are paying exorbitant prices, and people are either going uninsured or are underinsured, they and their families. Businesses can't grow. This was early on in our discussion. This was a real economic issue because it was affecting Vermonters' ability to grow our economy. We still are challenged to do this. The saying is culture eats strategy for breakfast. I believe that. And what we need to continue to do is press leadership and support the Green Mountain Care Board in their efforts to begin to change those dynamics.
The Green Mountain Care Board just decided that the Blue Cross Blue Shield large group insurance they wouldn't allow an increase of 17%. They brought it down to 13%. I know people that thought, well, okay, that's a victory, but wow, 13% is still a heavy lift after all the years of increases. Is regulation actually working?
I think regulation is working, but this is not going to turn over immediately. This is an urgent issue that needs continual attention and pressure, but we're talking about massive institutions with costs where we know we can find savings, but double-digit increases are painful. It absolutely, another year of double-digit increases is going to be really significant for businesses.
Yeah, just thinking about the balances that the Green Mountain Care Board had in approving that rate for the larger businesses. They're looking at a Blue Cross Blue Shield that is in financial trouble and maybe a few months of reserves at best. So they have to balance the needs of increasing what Blue Cross Blue Shield can bring in so that it survives. And they have to balance that against the need to control the costs at the hospitals. And to Lisa's point, this is going to be a bit of a roadmap. It's going to take some time to bring down the hospital costs to what would be the median in the country, maybe somewhere close to Medicare reimbursement levels, being able to operate on that. And in the meantime, they got to keep Blue Cross Blue Shield viable. So those tensions were, I don't know what was behind their decision, but those tensions in my mind were probably what they were balancing. And I'd say the other factor there is we saw one estimate that maybe affects 5,000 lives, I think, in Vermont, that particular sector of the insurance market. So it's not a large portion of the population, but to your point, yes, there was a moment of being disillusioned that another double-digit increase was allowed. But then I have to step back and say they've got to keep Blue Cross solvent while we go through this transition.
I guess, and I don't mean this as a criticism, but, Lisa, you've been around a while. How many times have people had this exact same conversation? It's either the Shumlin single payer that failed, it's the Hospital Data Council, it's the Green Mountain Care Board, it's people trying to make these radical reforms. And, I know we're all sort of looking for this magic bullet that's not there, but I just, I feel like the Yogi Bear, it's deja vu all over again.
Yeah, we certainly have had a few cycles of attempting healthcare reform through legislative activity and regulatory changes. I would say that we are in such extreme condition at this point. Our affordability crisis is affecting every aspect of our economy and our society. And we're hopeful within our group that we have developed an independent, objective approach to identifying the root causes of this affordability crisis. And we know where to look to find new models for a healthcare system that is going to eventually, quickly, we hope, be more affordable, provide better care, have greater accessibility for people who need it, and is going to be patient-centric. So, yes, we're at it again, but this time we feel that we really are empowered with data that has not been available or presented in such a way that we're finally getting the attention of leadership within the health network. They're finally sitting down and asking to meet with us. They want to know, what is your objective? What are you guys all about?
And you think that's sincere?
I do.
I would say, there may be 2 points of influence here that could change that direction. One is the board, as Lisa said, could become aware and take a deeper and more intense look at maybe the direction the network goes in and how they organize their governance, and they should. The second is when the University of Vermont Health Network came to agreement with the Green Mountain Care Board, the settlement over their revenue problems from last year, they agreed to allow a 5-member panel to effectively move in and work with the University of Vermont Health Network, dig into the business, the operations, the finance, and find out where the challenges are and the opportunities are to improve cost and affordability and quality. So those 2 things, either the board does it or this 5-member group exposes, which is being led by Mike Smith, who's got a long history of doing deep dives into complex situations like this. Either that panel will do it, the board will do it, and hopefully those are the 2 forces that come into play to change direction.
In the past, there were questions about how effective and strong the Green Mountain Care Board was. You've spoken highly of Owen Foster. I had a pretty lengthy discussion with him. Seems like a very impressive leader. I don't know much about the University of Vermont Health Network Board of Trustees. Are there people on that board? Is that a strong enough board, or is it like some organizations where the CEO puts into place people that are going to yes that person?
I would say yes to the latter. The fact of the matter is that there are people on the board who do have some conflict of interest. They are employed by the system. They don't live in Vermont. We all understand volunteer boards are volunteer boards, and this may not always be the biggest priority for them. However, this is the Vermont Health Network Board of Trustees that not only has a fiduciary oversight role, but it has the obligation to protect the people who are served by these medical institutions. And so it is vital that they have a measure of independence and use that voice and that role and that perspective in decision making. So Tom Galanka is the chair, and he has been willing to meet with us and talk about what they are aiming to do. We understand that he is working to increase the independence of some of the members on that board. So they recognize that that is a weakness that they're wanting to overcome that can benefit these processes tremendously. But at the moment, we are relying heavily, to Craig's point, on both that board and the group that's led by Mike Smith to be the sheriffs in town, if you will, for the health network.
Dr. Leffler has also told me, everybody thinks the University of Vermont Hospital here in Burlington is this big giant kahuna. In a lot of states, you mentioned California, it would be a relatively small hospital, that there's this sort of illusion that people have of the size of this. I can just hear them saying in response to this, well, you need to be careful here. You don't want to jeopardize the one major institution here in Vermont where you can actually get high-level surgery, high-level care. How do you counteract that? How do you deal with that narrative they're going to put out there of, well, be careful what you wish for?
Yes, and we have heard that comment. The fact of the matter is that the Health Network and UVM Medical Center, they are our big kahuna. If, relatively speaking, if they're, a mid-sized institution somewhere else, fine. But they're our gorilla, and so we have to deal with them. There has been a conscious set of decisions made by leadership over time that have brought us to this point. They have done a very good job, I would say, of neutralizing opposition within the community. The times are different now, and we are starting to turn the focus on them, that these are decisions you have made. It is time to say enough is enough. We have to start driving down costs to be more like national averages. We don't have to be this outlier. This is not a distinction Vermont can afford anymore.
When we come back, I'll share with you the comments of Tom Galunkin, who's the chair of the Board of Trustees of the Vermont Health Network, about the concerns raised by members of Vermont Healthcare 911. Back in a moment. At Red Hen Baking Company, they believe pure, uncomplicated ingredients in the hands of skilled artisans are the building blocks for great food. They're dedicated to creating the best food from the best ingredients. You'll find an ever-changing lineup of delicious pastries, sandwiches, and soups at their beautiful cafe off Route 2 in Middlesex, just off I-89. Their breads are also available in many other locations. Led by owners Randy George and Eliza Kane, Red Hen Baking Company has been on the leading edge of the local food movement since 1999. In response to my questions about Vermont Healthcare 911, the chair of the UVM Health Network Board of Trustees, Tom Galunkin, told 802 News, quote, "The members of the University of Vermont Health Network's Board of Trustees share the deep concern expressed by VHC 911 about the role of healthcare in Vermont's affordability crisis, and we had a productive meeting with them this week. The status quo isn't working for Vermonters, and UVM Health Network is taking action, including submitting fiscal year 2026 budgets to the Green Mountain Care Board, aligned with the Green Mountain Care Board's guidance and agreements, responsive to the cost reductions outlined in this year's legislation, and centered on preserving our commitment to protect direct patient care services. As volunteer board members, we oversee this work carefully, based on principles of good nonprofit governance and a focus on the needs of the communities we serve, and we are committed to holding the health system's leadership team accountable to our shared goals. We also remain committed to being a meaningful partner to working with any of our neighbors with constructive perspectives on how to approach this work with stakeholders statewide," unquote. In addition, network officials shared the 2026 budget proposals for the 3 Vermont hospitals under their purview and the amount they expect revenues to increase for the next fiscal year. For the University of Vermont Medical Center, the increase in operating expenses would be 2.2%, from $2.25 billion up to $2.35 billion. Operating expenses would go up 2.8% at Central Vermont Hospital and 3.5% at Porter Hospital. Network officials say administrative savings are expected. At 2 of the 3 hospitals, UVM and Central Vermont, the network says the amount charged to commercial insurers are projected to decrease, in UVM's case, by almost 8%. Perhaps the tide is turning. That wraps it up for this edition of 802 News, sponsored by Red Hen Baking Company. Thanks for listening.